is the most live guy here. Noel, I'm so happy speaking with you. This is an interesting subject. There, there, there had been, I don't remember if it was last year or the year before, some bad press. This is lay press about LASIK and some. I don't want to use the word aberration because it was a discussion about patient symptoms, but symptoms that patients were having. And the article was contested, and a lot of us feel rightly so. Your point is that, well, if I understand, is that there are some valid concerns and that we should address them, and you're going to talk about the tools about how we're going to identify and we hope ultimately address these issues.
Well, thanks again for inviting me, Josh. I always enjoy being on this event. You're quite right. There are people out there who are unhappy with the surgery, and they become more and more vocal, probably because they become more frustrated, because they're told what a great operation LASIK is, and it is, and we're talking about PRK and SMILE as well, I should say. And that is, there are people out there that are suffering from symptoms like glare, starburst, halos, loss of contrast sensitivity. I've seen a couple of patients myself who are actually from other practices, and these people are particularly troubled at night time. And together those symptoms as an acronym are called GASH, and that's what the lay press terms them at. But it isn't just the lay press like New York Times that came out in June last year. There's been letters to the FDA back in 2008, before and after 2008, discussing about people's outcomes, and to the point where the PROWL study was set up. And these symptoms of GASH was one of the things that the PROWL 2 study mentioned, was it was a surprise. So, you know, this so-called LASIK surprise, which is an unpleasant surprise, is completely a surprise to the patients and the doctors. But in fact, it's actually a very predictable thing, and it's avoidable. It's predictable because these people who are suffering from GASH usually have more differences between their corneal and refractive cylinder, and we quantify that by the ORA, or ocular residual astigmatism. And then if you're treating by parameters such as manifest refraction or wavefront refraction, which is totally refractive, all those internal aberrations of the ocular residual astigmatism, or ORA, are reproduced with corneal astigmatism. So there's some studies about, and particularly Dr. Frings from Hamburg, and my own study, somewhere between 34 to 46% of people have an ORA of 1 diopter or more. And that's a lot of people to have more than 1 diopter of astigmatism after the surgery. And the reason it's avoidable is because you don't have to have that much astigmatism left on the cornea. Dr. Maria Arbalez showed that in her study published in December 2017 in the Journal of Cataract and Refractive Surgery. And what she showed, comparing two groups, one totally refractive, one using vector planing, the vector planing group in fact had 41% less corneal astigmatism, but the real punchline is that their refractive cylinder was the same. They had no loss in quality of vision. In fact, they had better vision. So here you have an option of not having to suffer from these symptoms of GASH, because with 41% less astigmatism on the cornea, you're taking these people with an ORA of 1.5 down below 1 diopter, which I think is tolerable for the eye. So the limitation, or the limit, is you don't want to have more than 1 diopter of astigmatism on the cornea. Now, the laser companies, they've known about this for years, but they've disregarded it. But what they really need to do is to have what I would call is like a safe button, or a low astigmatism button on every laser, so that the doctors who aren't being given the opportunity to have this facility of vector planing, to be able to do vector planing on their patients, and to be able to avoid so much astigmatism on the cornea, which is avoidable and predictable. So when you put that together in another acronym, you've got what we call predictable, avoidable, LASIK surprise is PALS. It's a syndrome. Preoperative 1 diopter of ORA, postoperative 1 diopter or more of corneal astigmatism, and any 1 or more of glare, starburst and halos. So what we've done at ASOA is to actually provide the doctors, they can start using vector planing tomorrow on their next patient, we have got a facility or a calculator on the assort.com website, and they can do a calculation on every patient, and it's for free. So if the laser companies aren't going to provide it to the doctors, Assort will do that, and for free, just to get these patients out of the position where they're writing to the FDA or they're writing to any newspaper or social media. And that way you're going to have less people complaining about the operation, you're going to have happier patients, and everyone's going to be doing more surgery, because there's this little negative element they're out there demonstrating last year in front of this meeting. This negative element that's becoming more vocal out of their frustration that the problem isn't being recognised. So we should recognise the problem and solve it. So we have, instead of 95.4%, as Kerry Solomon's study showed, we should have 99% satisfaction rate.
Yeah, it's super that you have given access to these tools and that you're not charging for it. That's really, really wonderful stuff. I'm curious, what are the parameters that the refractive surgeon has to input into the tool?
So that was interesting, because I was at the ASCRS meeting in Aspen in March. So we had a show of hands in the audience, and I said to the audience of 200 people, how many of you quantify the ORA before the surgery? So the answer was pretty disappointing, like nobody. Nobody is even looking to see a quantity of how much astigmatism of ORA is there before the surgery. So they can't even counsel the patient and say, well, I can't really do a perfect job in your eyes because there's going to be some left behind. At least give the patient a little bit of insight that this might be a less than perfect case. So their expectations can be at a lower level. But then if they go and do vector planning, it pretty much solves it, because I've been doing vector planning for many years, and we very rarely see these kind of symptoms that are being talked about in the press.
Well, this is very, very practical stuff, and it's more than just to identify the problem. You've provided this tool for us. It's hopefully something that will be used. Uh, Noel, I want to thank you very much for bringing this important topic to us, a topic in the news, not just our news, but in the news generally, and a way that we can address it. And I want to thank you, our viewing audience, for participating in this live event. We have Noel's
I was going to mention one thing is, if you want to know more about it into more depth, specifically Chapter 9 talks about ORA, ocular residual astigmatism, and Chapter 13 and 14 talks about vector planning and its benefits and how to go about it. So it'll give people a broader understanding of what we've been talking about today.
Lovely stuff. Lovely stuff. I want to thank you for joining us, Noel. I want to thank you. I learned a lot, and I'm sure that you did too.
Well, thanks very much for the invitation, and I love this new format now I'm becoming a live performer. Nothing pre-recorded, so there's only take one is the last take.